but I'm going to go ahead and introduce our next panel. First, I have the pleasure of introducing Yasmin Regan, whose little ones you can hear in the room here today. Yasmin is a mother of 2 boys, Maddox and Alfie, and she was diagnosed with postpartum depression and anxiety in May of this past year, and she's still battling some of these struggles as we speak, and we thank you for being here and being willing to share your story. Yasmin is advocating through social media for mothers experiencing postpartum mood disorders. We're so glad you're here. I'm next going to introduce Dr. Phillips. Megan Phillips is a licensed psychologist in private practice here in California in Orange County. She's also a survivor of postpartum depression 2 times over, as I think so many women in the room may be, or those listening online. She became acutely aware of the lack of properly trained providers to treat these disorders, and she earned her perinatal mental health certificate from our partner organization, Postpartum Support International. Thank you, PSI, for developing that certification program for experts in maternal mental health. She has grown her practice to have 2 locations and 5 clinicians in her practice. We thank you so much for joining us, Dr. Phillips. And for those of you who were with us last year, you might remember that Dr. Phillips stood up while she was actually pregnant and asked some difficult questions of one of the other guests on our panel. So it's going to be a fun conversation today. So we thank you both. Next, I have the pleasure of introducing David Lloyd, who's in the middle here. David is a senior policy advisor at the Kennedy Forum. Many of you may know the Kennedy Forum is a nonprofit sort of think tank addressing mental health parity, or mental health policy, including mental health parity legislation nationally, and supporting states in developing policy as well. Mr. Lloyd has served as a legislative assistant to the U.S. Senator Debbie Stabenow, and also served in a variety of leadership positions working on mental health policy. And we're so thrilled that you're with us and that the Kennedy Forum is represented. I also have the pleasure of introducing Tim Clement. Tim is the Director of Legislative Development at the American Psychiatric Association, the APA. He's an expert in both federal mental health parity and addiction, and the Federal Mental Health Parity and Addiction Equity Act, MAPIA we call it, and similar state MAPIA laws. He has drafted model legislation pertaining to mental health parity, and also the psychiatric collaborative care model, which I'm really interested in learning more about as well. So we're really thrilled that Tim, with his deep-rooted expertise in mental health parity, is with us today. And then finally, I'm introducing Dr. Stuart Lustig. We heard a little bit about Dr. Lustig coming from Cigna, and you all may remember Dr. Lustig has been with us in the past, so welcome back. He's currently the National Medical Executive for Behavioral Health at Cigna. He engages with clients, provider groups, and other stakeholders, and he is a board-certified psychiatrist specializing in child psychiatry. He's also served as the lead medical director for child and adolescent health for Cigna and various issues. He's really fantastic in serving his community in multiple ways in the San Francisco area. And also, you may recognize him from television because he is featured in several of Cigna's ads around mental health and well-being. So welcome to you, Dr. Lustig. It's great to have you. So up next, we're going to pull up the PowerPoint that we have both David Lloyd and Tim Clement presenting today. And you're going to get, I hope some of you feel like you have capacity to be a bit of a policy wonk, because we're going to hear a little bit about federal mental health parity law today, and it can be complex, and they're going to do their best to give us all a good foundation. We're going to talk, though, not just about current federal mental health parity law, but access in general and the struggles around access and mental health, and talk about some potential new levers around policy on this panel. So we're really excited to have you. And Sydney, if you don't mind helping us pull up the next PowerPoint, that would be great.
Good morning, everyone. It's a pleasure to be here. And so David and I are going to talk a little bit about just the concept of parity, the federal law that exists, and a little bit of the history as well. This can be a very dense issue, so we don't want to bog you down in the weeds. We'll just get into some of the broad contours of the law and the concept, and then move on from there. So as you can see, the basics, it's a very, very simple concept, the parity is, that mental health and addiction insurance coverage should be no more restrictive than insurance coverage for any other medical condition. So I think at its heart, it's a very simple and easy to grasp concept that the illnesses of the mind should be treated and covered the same way as illnesses of the rest of the body. However, you might be asking yourself, okay, well, if it's so simple, why did we need a federal law requiring that there be insurance coverage that was no more restrictive? And that's because historically, mental health and addiction insurance coverage was much, much, much more restrictive than it was for other medical conditions. This is something that was basically true throughout the history of mental health and addiction insurance coverage. For instance, very frequent up until the federal law that passed in 2008, there were strict limits on how many days you could be in an inpatient mental health facility or addiction facility, strict limits on how many visits you could get to a psychiatrist or a psychologist or any other mental health or addiction professional. Oftentimes, co-pays and co-insurance for mental health and addiction insurance coverage were much more expensive, or you'd have co-insurance for mental health and addiction that would be a much more expensive thing, and you'd have co-payments for other medical visits. And then one thing that was very, very common was a separate deductible for mental health and addiction insurance coverage. So you'd have your regular deductible for medical care, and you'd meet that. But then when you needed mental health treatment, you have to get another deductible. And sometimes that deductible would be more expensive than your deductible for other medical care. So that's sort of the historical context of why there was a need for federal and state action on this issue. So if you want to look at the history of parity, it actually goes back pretty far. So back in 1961, President Kennedy, President John F. Kennedy, he required the federal employee health benefit plan to have parity with other medical conditions. So it was basically, that was sort of the first step. And it's not a surprise that you'd see a Kennedy sort of lead the way on this. The Kennedy family, they've long been strong champions of mental health, and treatment and coverage. In fact, the last act that President Kennedy ever signed into law was the Community Mental Health Act in 1963. So in 1961, President Kennedy established that. However, unfortunately, through future administrations, that got scaled back a bit extensively in 1975, and by 1981, it was completely gone. Then our next major step was in 1996. Congress passed the Mental Health Parity Act. However, this was a very limited and almost superficial change. It really had very minimal requirements, and of course, it only applied to mental health coverage and not addiction coverage. Then in 1999, President Clinton basically redid what President Kennedy did in 1961. He required that the federal employee health benefit plan be at parity for mental health and addiction coverage with other medical care. And then, of course, the big game changer was back in 2008. Congressman Patrick Kennedy, David's boss, my former boss. Oh, sorry. Back in 2008, Congressman Patrick J. Kennedy, David's boss, my former boss, he sponsored the Mental Health Parity and Addiction Equity Act, which was signed into law by President Bush, and that required initially all large employer plans to comply with to have parity for mental health and substance use disorder coverage as for other medical care. And the big thing here was also it extended the coverage to substance use disorders, whereas previously parity had just been something for mental health coverage. And then in 2010, the Affordable Care Act built on that and extended the parity law to individual plans and small group plans. So an additional 63 million Americans now had parity protections after that. Then finally, in 2013, the final regulations for the federal law. So one thing that happens with laws and legislation is once a piece of legislation is passed and becomes a law, oftentimes there need to be regulations issued by federal regulators to add in some specifics. So that took place in 2013, and that's really where the bulk of the requirements of the federal parity law are contained within those federal regulations. And then in 2016, those regulations were extended and issued for Medicaid as well. So just getting into some of the specifics here, we won't get too deep into any of the terminology here, but there's some broad components of what the federal parity law requires. Basically, it's mental health and substance use disorder must be compared to medical and surgical benefits. There's three major buckets. One is financial requirements. Those are things like co-pays and co-insurance and deductibles. The law has very specific requirements for that. It also has requirements related to quantitative treatment limitations. Those are the hard limits on care that I mentioned earlier, like inpatient day limits, outpatient visit limits. And for these first two buckets, the insurance industry, I think, has done an outstanding job of coming into compliance with these issues here. I think you see some of those restrictions that we used to see in place, like more expensive copays or hard visit limits and day limits. Those things have mostly disappeared thanks to insurers coming into compliance with those aspects. And then the last part of the law is it requires something called non-quantitative treatment limitations, a very complicated term. And David's going to talk a little bit more about that, but mostly what that refers to are insurers' managed care practices, like things like prior authorization, how they design their networks, how they set reimbursement rates, and many other things. So the law has very specific requirements as it applies to those managed care practices. And basically what it requires is they be comparable and no more stringent for mental health care than they are for other medical care. The law also groups everything into the separate classifications of benefits. You got your inpatient classifications, your outpatient classifications, prescription drug and emergency. That's where all the parity analyses must take place. And of course, one thing that's very important to note is the law requires compliance both with written materials, but also how things are done in operation. So for instance, if you have a prior authorization, let's say, for someone who's in a mental health facility or being transferred to an inpatient unit from emergency department, the way that prior authorization by the insurance company, the way it takes place, has to be no more strict than what happens when there's a prior authorization for other medical care. And that's an aspect of the law that can be quite challenging to implement. But I'll stop there and pass it over to David.
Great, thanks, Tim. And I'll talk a little bit more in detail about these, the managed care practices, these non-quantitative treatment limitations. So as Tim mentioned, it includes things like prior authorization requirements, provider networks, setting reimbursement rates. Basically anything that doesn't fit in the other two buckets fits in this bucket. So any managed care practice that limits treatment that health plans use. And there have been several reports that we think show that there are still problems in this area. And we continually hear that from people who contact us that they're having problems with managed care practices that seem, at least on the surface, to perhaps be problematic from a parity perspective. But the actuarial firm Milliman did a report both in 2017 and then in November of last year that looked at how often patients had to go out of network for mental health and addiction care compared to other types of health care. And they found pretty dramatic disparities in how often people had to access care out of network. And that, of course, means that because out-of-network care has higher co-payments, higher deductibles, et cetera, that you're paying more out of pocket. And the cost is really borne by the patient, and it's hard to find the care they need. So that is also kind of under the Parity Act kind of covers these issues, and in many states, it was the disparity was 10 times more often people had to go out of network for mental health and addiction care compared to medical surgical care in inpatient and outpatient care. So health plans are required under the Federal Parity Act to actually do analysis that shows that they're in compliance. So they basically have to say, what are our practices on the mental health and addiction side? What are our practices on the medical surgical side? And do a comparison to make sure that they're in compliance with the law's requirements. Unfortunately, we think that that isn't occurring as often as it should, or that isn't plans aren't going, aren't meeting the requirements of the law. At least some plans. But this can be a very tricky area for consumers to police themselves because they simply don't have the information that they need. So they may they're not experts in mental health insurance law. They're not the denial letter that they might get might not provide enough information. They might not get requested information that they request, even if they should get that information. So we're really focused at the Kennedy Forum, the American Psychiatric Association, at getting state regulators to do more to ask for the parity compliance analyses up front to make sure the plans are compliant, so that we're not relying on people who are in crisis, in emergency situations, trying to find the wherewithal, to complain, while they're trying to keep either themselves or their loved ones perhaps alive, that they also have to try to complain to the Department of Insurance in their state. So that's one thing that we're pushing, and that we think is important to proactively ensure compliance. And finally, there is, I won't get too much in the weeds here, but enforcement is both done at the federal level and the state level. So many different types of plans, especially for large employers, like large corporations. The oversight is handled by the federal government. For many other types of health plans, including for Medi-Cal in California and Medicaid programs across the country, it's primarily a state function that oversees parity requirements. So I won't go into the weeds there, but just know that there are different regulators who handle different types of plans, and it can get kind of complicated. But so we're working with both federal regulators and state regulators to try to improve compliance. And really, the goal is to make access to care a reality so that people can get the care when they need it. And the good news, though, is that state regulators in particular are becoming more engaged. I was very pleased to see that Governor Newsom a couple weeks ago made parity compliance a priority in his state budget address, which is very positive news. In other states, they're actually requiring that plans submit this comparative analysis up front so that the regulator can see if in fact the plans are compliant. So we think we're making a lot of progress. And additionally, the main National Association of Insurance Commissioners is making progress on this as well. So we're gathering momentum, but we know there's still a long way to go.
I just want to comment briefly that to me this is a great example of when policy really matters. If insurers wanted to do some of this work on their own and might know that this was important, they would feel like it was difficult to adopt these kinds of policies, because what if, for example, Cigna decided we want to do much more of this, but other insurers did not? It's called adverse selection. So we might have more sick patients, right, come to Cigna instead of distributing healthy and sick people and patients more uniformly. And so it's important to have this sort of foundation. This is where policy really can make a difference. So thank you to the Kennedy Forum and to each of you who are really paramount in ensuring that these laws were passed. Wonderful. Well, I want to start, and you heard today that we learned actually from a double board certified psychiatrist and pediatrician when we started this work 9 or 10 years ago, to always start with a story, like lay the context with a story. And Stephen, amazing to start the day out and the event out with your story and your access struggles too. And I wanted to invite Yasmin to join us on stage for this panel. What we're finding, of course, is that social media can be an amazing way for us to connect. And we as 2020 Mom hear often from mothers who are struggling with access through social media. And we had the opportunity to hear from Yasmin about 4 months ago, about some of the struggles she was having with access. And I felt it was really important for her to come and tell her story on this panel. And so I'm going to turn it over to Yasmin now. And I think we'll pass one of the microphones down, if you don't mind, to just tell us a little bit about her journey.
My name's Yasmin. I was asked to do this back in October, and I was for sure thought I would be ready until right now.
Isn't that a is that not? That's a beautiful accent, isn't it? And so we're going to ask her to tell a little bit about where she came from and how she got here too.
Yes, I'm definitely not American. I've been in the States since 2012. I'm originally from Australia, and it's probably going to be really thick because I'm trying to get my point across. When we were talking about certain risk factors for PPD, I was never presented with, do you have this, do you have this, have you had this trauma? And so when I was diagnosed, I was completely blindsided. So going back to that, I was originally married to someone that brought me over here. with a wonderful life and everything, and he was extremely abusive. So I left him because if I didn't, I don't think I would be here. So I know for sure that that played a huge factor in me getting PPD. I never got therapy or anything like that after that. So that's what brought me over here. So I am now happily married to my husband, and I got the 2 babies over there. So basically, I'll start on my story, and I'm going to try really hard to hold it together. I had Maddox in January of 2018, and I never forget, he was a week old, and I had my mother-in-law holding him, and I just felt like I was shaking, I was sweating, I knew there was something not right. I just knew that this was more than first-time mum. But due to lack of maternal mental health education, I told myself it was neurotic first-time mum, I'll get over it eventually. I didn't. That then in turn turned into postpartum OCD, which is not spoken about as much as it should, because postpartum OCD can bring on those intrusive thoughts that a lot of mums unfortunately experience. So I've had this for 2 years, almost just over 2 years. I got pregnant with my second when Maddox was 7 months old. So they're 16 months apart, and this is when it starts to get hard, because around 30 weeks, I started experiencing depression, and I've never felt depression a day in my life. I've always kind of been the positive person, and I was getting fits of rage. My dog barking was enough to just send me over the I couldn't handle it. So I went to my, he can hear me talking. I went to my obstetrician at 30 weeks and I said, I think I have depression. I think there's something wrong with me. And he said, okay, let's have the baby and we'll go from there. So I had Alfie at 39 weeks due to high blood pressure. So that was an additional 9 weeks of me suffering and thinking it was all in my head. So I remember I was heavily pregnant, probably about 38 weeks pregnant, and I said to my husband, there's something wrong. I don't want this baby. I want to have him and just leave him in the hospital. I don't think I can do this. And that's when I knew for sure there was something wrong, because all I've ever wanted was to be a mum. That was just my calling. So nonetheless, I had him, and that's when it started. They hand you a child and 2 children. My Maddox was only 16 months. And he knew that I had depression and showing depressive symptoms, and I called every single day for 2 weeks to get an appointment because I knew that I had PPD. This is so hard to talk about because I was literally fighting for my life, and I had to fight to get an appointment with my doctor. So I called and I said, I think I have postpartum depression. So the nurse gives me a bunch of random intake questions, and she asks me if I had thoughts of harming my children or myself. Thank you. My makeup's going to get all messed up. It's the first time I've worn makeup in forever. I'll just take these off. she asked me if I was going to hurt myself or my children, and I knew I would never hurt my kids, ever. But I had thoughts of harming myself because I felt like such a goddamn burden, and so like I was failing everyone, and I was too ashamed to admit that I had those thoughts. And she said, oh, that's okay. You don't have postpartum depression because you're not having suicidal thoughts. It's just the baby blues. And I swear to God, those words will forever stick to me because I know my body, I know my frame of mind. So she said, go and relax, take a nap, because that's so easy to do with 2 kids. And then she said, try not to worry because the stress can pass on to your breast milk. And she was a nurse at my obstetrician's office, so if you've got a nurse at your OB's office telling you that, there's something wrong. So I was like, okay, I'm going crazy, that's it. And my suicidal thoughts got worse and worse and worse because I literally thought I was going crazy. Nonetheless, I fought like hell because I have 3 people that are relying on me. And I got that appointment. And he again asked me if I was having suicidal thoughts. And he said, before you answer, if you say yes, I have to commit you to the psych ward right now. I had a 2-week baby who was breastfeeding, and I had my oldest and my husband who's a shift worker, so you can't just... So I lied because there was no way in hell I was going to go to the psych ward and be treated. Like, I was crazy because I'm just a mom. I'm not crazy, you know? I don't need my belt taken away from me or my shoelaces taken away from me. I needed help. So he put me on Zoloft, which did nothing. And he said, I'll start you off at 25, but, you know, cut the pill in half to get used to the antidepressant. He says, but don't use that knife to slit your wrists. You'd think I was making this up, but I'm not. So then I started Zoloft, and I went into therapy. And she was the only person that could get me in because she accepted my insurance. And she claimed that she was well-versed with postpartum, but I'm going to tell you right now, she wasn't. Because the first time I met her, she told me to stop breastfeeding because it can be a huge contributing factor to depression. PPD, I'm sorry. And little did she know the reason why I was continually, and so I'm still breastfeeding now, is I thought I could rewrite the bad thoughts that I had in my head when I was pregnant with him to just make them go away if I breastfed him. So being told you need to stop breastfeeding was not good for me. So I went to her for 4 months because I had no other option. In between those 4 months, I was fighting with my insurance company because they wouldn't allow me to go and see a postpartum versed therapist. They told me that I could just go and see anyone that accepted my insurance, but obviously when you're dealing with intrusive thoughts and everything, people automatically think that you're crazy and you're trying to rationalize with a professional, and they make you, you know, think that you are actually crazy. So I found my therapist through Joy. She helped me so much, and I'm now with her for a couple of months, and she has been able to open up a whole different level of what I'm dealing with, and I don't think I would ever be able to get this far without someone that obviously isn't well versed with postpartum depression. So it's a very long-winded story, but I'm just trying to keep it short. But basically now I'm almost 9 months postpartum and I'm still struggling. Every day is a challenge, but I still get up and obviously show up for my family because, and I'm also advocate for a lot of mums on my social media page because Stephen, I knew about you, and I had Alexis in mind because I wished that she could go on a page like this and see that she wasn't crazy. So she's my drive. I've never said that before, but I actually posted a picture of her and your daughter and said that she is my drive to make sure that we don't lose another woman because of cracks that are so damaged. Medical practitioners need to be more educated. And if I have to stand in front of every single doctor in America and tell them that they're the ones that are crazy for thinking that intrusive thoughts are crazy, I will do it. So, thank you for listening.
How lucky are we to have Yasmin here? I'm going to do that too. One of the things that I want you to know is there was a lot of work trying to navigate the insurance system behind the scenes with Yasmin. It wasn't Cigna, another behavioral health care company in New York, who's actually is trying to do a lot of work in maternal mental health, but not one single provider on Yasmin's panel that had received training in maternal mental health. And so she's seen someone now out of network and has received commitment from us and her therapist that we're going to figure out a way to make it work, but this shouldn't be the way it works. Yeah. So I want to start by asking Dr. Phillips to talk just a little bit about what you see and how patients are able to access care. And I also, again, want to acknowledge that there's been incredible policy work that really, the way I frame it with mental health parity is it's sort of benefit parity between medical benefits and behavioral benefits, right? Benefit parity, but there, we believe, still more work to do. And after Dr. Phillips talks a little bit about what she's seeing and hearing from her patients, who may finally find you, we want to hear about that first. We're going to move back to Tim and David to talk about what's left to do in terms of monitoring network adequacy, for example. So Dr. Phillips.
So first and foremost, Yasmin, that was amazing. You are a warrior. I just want to let you know that. I think all of us were deeply moved by your story, and I almost feel I want to apologize on behalf of the entire mental health field for all of the cracks that occurred on your journey to get help. That should not happen, straight up. And sadly, it happens every single day. I'm pretty sure we're all in good company here. I'm guessing, by show of hands, who in here is a mental health professional? Yeah, exactly. So my guess is that my experience is going to just echo yours. I get 10 to 15 calls a day. I literally had to just hire someone to field these calls because I got so many of women telling me pretty much the exact same story of how they were calling many, many people. They could not find anybody who did this work, or worse, they found somebody who said that they did this work but couldn't do this work. And the distinctions are, of course, it's not just depression after a baby. It's postpartum depression. There are many other nuances that go into that. And if you are not trained, you can actually cause harm, which is what we clearly know. So there's kind of two-pronged problems that occur, I think, but thanks to the wonderful work that Joy and the 2020 Mom program has really done, is that in California, at least, we're screening moms. whereas a decade ago we weren't. So not only were moms highly stigmatized for experiencing postpartum anything, they had no idea how to get help or who to talk to or where to turn. And then we did wonderful things where we created these screening tools and we required medical professionals to learn how to do that and to ask at least once, hopefully more than once, in that first year after baby. So now OBs are required, or else I think they get punished, I hope they do. They're required to screen moms. Pediatricians are even sometimes asked and maybe even close to being required to screen moms at the pediatric appointments, which of course are most of the time you're going to catch these moms, because that 6-week postpartum visit, people are like, I can't sleep, I don't know what day it is, I have no idea what's going on. Maybe they have a little bit more clarity into how they're experiencing their postpartum adjustment concerns after the couple of months in, and they're like, oh, this isn't going away. So I'm hopeful that that is creating a new wave of awareness, which I think it is starting to. The problem, of course, becomes now we're screening everybody, and they're recognizing, oh, I might have a problem, now where do I go next? And of course, everyone's being told the same message, you go to your insurance company, because no one wants to pay hundreds upon hundreds of dollars a month to go see a specialist if they don't have to, and if they have insurance benefits. So they're told, go to your insurance and find a provider. And everyone's supposed to have that work out just great. And it doesn't. It almost never does, because what you see is a list of 20 to 30 people on a spreadsheet of your zip code. Here are some therapists in network, go, good luck. And then the patient calls every person on that list, maybe gets one person to return a phone call. That's a big problem. And the person that they might actually get on the phone who can actually take them on their calendar because they're so darn booked up doesn't have any training in this area. So then we have a huge problem. And they may go to that person and not get optimal treatment, or they go with the next option, which is what these gentlemen talked about, which is they often access out-of-network care. And of course, you're up against a lot of financial burdens there too. Out-of-network deductibles are oftentimes magnitudes higher than regular deductibles. Out-of-network coverage pays anywhere from 20 to, if you're really fancy, 80% of what you're paying that provider. And it's hugely a financial barrier. But there's another major giant red flag reason as to why this is occurring, and that's the problem with the insurance reimbursement situation, as I'm sure a lot of you know. I have a wonderful colleague in the back who actually really helped me identify, because we're in Orange County, and which we divide in mentally, not like geographically, into North Orange County and South Orange County, because apparently we can't interact. And we try to take a poll of all of the maternal mental health specialists who actually have training and who take insurance. And we were like, let's put together a fancy brochure so we can give these to doctors, so when they're screening all of these wonderful women who are experiencing really down point in their lives, they've got someone that they can send the person to who takes their insurance. Do you want to know how many people are in our brochures? About 10. 10 for North Orange County, and what was it, like 10 for South Orange County? Oh, 8. It went down. That's how many we have in a population of millions of people who are trained in this field, who take insurance, or who even offer sliding scale to allow people to access care. And that is because insurance reimbursements are crap. Am I allowed to say crap? Well, I just did. Insurance is not valuing this as a specialty. They're not valuing mental health care as anything. There's no payment parity. We talk about mental health parity, where we get treatment for these conditions, but we're certainly not paid for these types of services. And it's not okay.
Thank you. Thank you, Megan.
Yes.
And I give you permission to say that word if you
Thank you.
feel like you need to.
Retroactively.
Before we actually turn it over back to Tim or David to respond, I think Stuart, as a behavioral health insurance company, I think we'd love to hear, like, what are your reactions, and talk a little bit about some of the things that Cigna is doing. Cigna, I think, is doing some good work here.
I thought I might get this opportunity sooner rather than later. So Dr. Phillips was here last year, sat right back there in a spot that is forever emblazoned in my memory, and in the Q&A told me that the reason she was no longer taking Cigna insurance is because our rates were not competitive with the other companies that you were accepting. And so my first thought was, okay, keep your friends close and your enemies closer. So we brought her up on this panel. No, I'm just teasing, actually. I'm very glad that you raised that point. We remedied that right away, and I'm thrilled that you're actually on our panel at this point. And I will say, in fairness to Dr. Phillips, what you were asking for was entirely reasonable. You weren't asking for some exorbitant amount, right? It was just to kind of match where the other folks were, which was easy enough for us to do. So I will say it is very concerning to me to hear Stephen's story, and my brain first went to my first kind of defensive thought, well, okay, well, that was how many years ago now? 8, 9 years ago at least. Hopefully, okay, 7. Hopefully we've made some progress since then, but then hearing your story, Yasmin, is a real wake-up call, quite frankly, because here we are in 2020, the year for which this organization is eponymous. I was waiting to use that word. And we're still dealing with the same issues. So the kinds of things that we're doing at this point, first of all, we don't just give people a list of 20 names, 30 names. It's sometimes quite longer than that. We are also more than willing to make those phone calls, send those emails, do what are called customer service searches. And the reason is because, quite frankly, if you're juggling 1 kid or 2 kids in your arms, the last thing you have the time or energy to do is be calling 20 different providers and getting very much the same kinds of answers. The second thing is you found out easily enough is if there's some rate that's getting in the way of being part of our panel, we want to hear about that, and we want to be able to meet folks where they're at. Our experience is that folks have not been demanding exorbitant amounts. Most people in this room want to participate in our healthcare system, and that means working with insurance so we can offer affordable care to the clients, the employers that we work with. Most people are not asking for $600 an hour for psychotherapy. So, all reasonable offers, I think we're happy to entertain. On our website, and this is been true for a while, but you can look to see who actually specializes, who has some comfort and expertise with this particular field. And it is concerning to me to hear that the numbers are so low when you looked at how many folks were actually working with insurance. So that is a call to action for us. And I can say more, but I'm getting the nod, so I'm going to...
That means, yes, we agree. And again, just one more shout out, if we could. Cigna helped the field identify that there was a need for a certification in perinatal mental health, because insurers can't check, okay, this person said that they were trained, but do we say that they're an expert just because they received a little bit of training? And again, just want to thank Postpartum Support International, Wendy Davis, executive directors in the room, for developing this certification that Megan has received and others, and Cigna is now reimbursing those trained providers at higher rates. We want to see more insurers do the same.
And Joy, kind of one other thing worth the applause. One other thing to add is if folks cannot find care within network, we cover that care at an in-network rate, even if folks have to go out of network. So people are not penalized for a network adequacy issue with an insurance company, at least for us, and hopefully that's true elsewhere. Thank you.
A policy point on that front is that California actually has a state law that requires, if there's a network adequacy issue, that insurers reimburse at in-network levels in terms of patient copays, and that a letter of agreement be put in place with that non-par provider. And Cigna does a really good job at addressing that. We're going to turn it over to our policy experts for response.
Yeah, just to follow up on that point, the single case agreements. This can actually be a problem if you're trying to negotiate a single case agreement that's very low, and the provider won't accept it. So we're actually looking at strengthening some of these requirements, because we actually think if the insurer doesn't have in-network providers who meet the patient's needs, then there shouldn't be any flexibility in covering out-of-network care that's appropriate. And so where state and federal laws don't ensure that as an actionable right, that we should make that an actionable right. But I guess I would put, and I think insurers hopefully are increasingly stepping up to the plate, but I guess I would like to challenge insurers to make sure that they have adequate networks for every type of provider that their members need. Now, obviously, there are other issues in terms of workforce shortages, but where there are providers in Orange County and there's a lack of in-network providers that meet their enrollees' needs, they need to be increasing the reimbursement rates until they get those people in their networks. Because if they don't do that, then we're in this kind of bizarre situation where, where there's kind of this back and forth. Basically, it's finger pointing, and you don't get the in-network coverage that people need. So I would like to, put it on the insurers that they actually have to raise network rates until they get an adequate network, which is what you see in things like oncology and other areas, that if they don't have enough oncologists, they will raise rates until they get enough oncologists. So I think that's a critical step that needs to happen.
But before we pass the mic over, how does this work practically speaking? Is it that an insurer would say, we're going to pay all perinatal mental health specialists or all child, OCD specialists? Like, do we advertise the rates on a website? Like, what's the practical way to implement this step? Because I think it's important. Or do we say, attention all therapists, start calling Cigna and Aetna and everyone now and, ask for such and such amounts? Like, how practically do we implement that step?
If that's for me, yeah. So a few things. First of all, I think for us at Cigna at this point, we have an any willing provider policy. That's new. So it used to be we looked at different markets, and a lot of these rates are market specific. So what you might be paid in Boston is going to be different from what you're paid in Topeka, and it's based on partly supply and demand. It's based on cost of doing business, cost of living, a whole host of factors that are market specific. So hard to have a broad umbrella, but certainly we have a general sense of what people are making out in the community, and how close we can get to those rates. The other thing I'll also say is, look, I think everybody deserves a raise. And it's very reasonable to talk to the insurance companies you're working with on a regular basis, once every year, once every 2 years, and say, look, these were the rates that I paid last year, and I need to pay my office staff a little bit more, and my rent has gone up, and by the way, I'm a better therapist even than I was 2 years ago, so let's talk rates again. Very reasonable conversation, and people forget that they can have that conversation, and I think that's partly because we look at insurers, and I understand the reasons why for this, but we look at insurers as these vast behemoth bureaucracies, and what they say goes, so it's either take it or leave it. And you can come to here and stand up in that corner and make the point, or you can just give us a call, and they both work very well. So please call us for any questions about rates. Sure.
Yeah, so I think some great points brought by Stuart and David. And I think that, when it comes to networks and the availability of providers and reimbursement rates, the Parity Law actually does apply to that stuff. And I think that, Stuart just mentioned something that's very relevant, supply and demand. Right now in the United States of America, every day 300 people die of a drug overdose or a suicide. And demand for behavioral health services has never been higher. And yes, there are shortages of providers. With every other kind of medical specialty, when you have a scarcity of providers and an intense demand, rates go up. That's what supply and demand is all about. And I don't think, it sounds like Cigna is responding in a way that is appropriate, but I don't think we're seeing that across the spectrum of payers. I think we're seeing that the rates are the rates, and the rates are going to be what the rates are going to be, because that's what we've paid and that's what we're going to pay. And I think that a lot of our members do find it's a take it or leave it situation, not necessarily with Cigna, but with many payers. And I think that, with other medical conditions, if you had someone seeking treatment for, a heart attack or, cancer or something like that, and you said, well, we only have 3 in-network cardiologists and they're all booked up, I'm sorry. Or that they were only paying cardiologists $140 an hour in reimbursement, and a cardiologist could get $300 an hour, out of pocket. You're not going to find too many cardiologists taking that, and you don't see that at all. The day that an insurer would say, well, that's the number of cardiologists we have in our network, I'm sorry. You're just going to have to wait for that heart attack. You're going to have to get that treated somewhere else. That insurer would be on 60 Minutes the following week, and that's something that we hadn't seen in the behavioral health side of things, which we are seeing now. I do think we are seeing that change, that shift, that emphasis and that pressure being put on by the media, by the public. And I do think the insurance industry, I do think they do want to get there. I think, as Stuart just mentioned, they are willing to. So I think that I would recommend that if you are experiencing rates that are what you think are abysmally low, have that conversation, have that negotiation. Part of supply and demand is to make sure that those that are the supply make sure that it's known to those that are paying that, look, there's a huge demand for these services and I can't meet it and I can't survive in network given the rates that you're giving, and then maybe they will negotiate. But the Parity Law does require that the way insurers design and maintain their networks has to be comparable to what they do on the medical side. And the same thing when it comes to setting those reimbursement rates. So while the law doesn't say that the reimbursement rates have to be exactly the same, it says that those factors like supply and demand, market, scarcity, have to be comparable in terms of how they apply them. So I think that we're looking at a time where rates are still lower for behavioral health providers than they are for other medical providers, yet you have such a huge unmet need and demand, and you have people dying by the hundreds every day. So that's all I'd add.
Can I offer just a quick negotiating advice
Please.
for folks? When you call your insurer, one of the things we're very interested in is, are you already, if you're in our network already, right, where you think you've signed on for life to the rates you got back in 1972, it's helpful if you can say, look, I am taking care of 16 of your patients, right? You should say that. You should tell us how many patients you're taking care of, because that tells us that we have relationships that we want to preserve with those patients. We don't want to see those patients have to go elsewhere if they're getting good care from you. And if you're not in our network yet, you can tell your insurer, whether it's us or someone else, by the way, I have 3 or 5 single case agreements already with on behalf of your patients, if it's Cigna, right? And that tells us that, okay, this, we can do the math, right? Just like you can. We'd rather have you in our network and work something out that's going to work for many more patients than the 3 or the 5 that you have single case agreements with for out-of-network care. So use those numbers when you come talk to us.
Helpful.
Sorry.
Thank you.
Yep.
Gentlemen, I have a question for you. This concept of single case agreements, again, the network's not adequate. Patients might call 7 people on a list and then not know what to do. They go out of network. Does it seem like there's a policy opportunity to disclose the right to request a single case agreement, national policy opportunity there to patients, and also to have insurers issue denial letters? What happened with Yasmin's situation is we knew that we could request a single case agreement, and so we helped navigate that system with her insurance company. But guess what? No written denial letter. So we have nothing to appeal. When there's no written denial letter and you can't appeal, then it's sort of this phantom no, right? A phantom no with no documentation that we can't act upon. Your response, is that an opportunity?
Yeah, I think the rules across the country vary, but no, I think that people should know what their rights are and should be able to assert those rights without going through a Kafka-esque system, where they get lost and can never get out. So I think that is critical. And I'm sorry, the second part of your question was
Documenting no's for single case agreements.
Denial. If you're not getting a denial letter and you've been denied services, that's against the law across the country. And we would hope that regulators would be policing that pretty aggressively. I see a lot of instances, frankly, where we have people complaining that that's not happening. Granted, they're coming to us because they're having problems. But no, that is, and I think some insurers may frankly use that sometimes as a strategy, because if you don't have a denial letter, it's much more difficult. So they're good actors, and they're perhaps a bad actor or two. So it's really important that regulators be overseeing these laws, because if you're denied services that you're requesting, you should be getting a denial letter.
Great.
Yeah, and just one thing I would add too about denials. A lot of times, unfortunately, and I think many of you in this room might be familiar with this, particularly if you deal with the inpatient side, is if you're seeking, let's say, coverage for an inpatient stay, the insurance company will often give you the option, do you want to, I can deny this and you can try to appeal this, or do you just want to take an approval of intensive outpatient treatment or some lower level of care? So you end up saying, well, I want my client or patient to get care, so yes, I'll get approved for that lower level care. So you're denied that inpatient benefit, but it never shows up as a denial because you're accepting the outpatient treat coverage because you want your patient to get something. So a lot of times for there to be an actual denial, the provider is going to have to say, no, I'm not going to accept any level of treatment for my patient right now, and I'm going to appeal this. And that's something that can be challenging. That's a bit of a quirk and a bug in the system, but it is sometimes a problem.
Yeah, really good point. I wanted to bring up one other topic, and then we're going to ask each of you to leave us with any parting remarks that you might have. Well, two topics. Workforce shortages. So I'm curious, our policy folks, and also Dr. Lustig, if you're familiar with any efforts to recruit certified peers. So we have a panel tomorrow on certified peer specialists, but we know all 49 states, California is the one exception that doesn't have a certification process in place yet. That should change soon. We know Medicaid is reimbursing for services around use of certified peer specialists. Any thoughts on recruiting both certified peer specialists to augment shortages? And then any other comments, I guess, around shortages and telemedicine, telepsychiatry? You know, what kinds of trends are you seeing in this space?
Well, yeah, I think so. A number of insurers have been stepping up to cover peer support because they see the evidence that shows that it's so effective. The people that get peer support, in addition to support in treatment from whether it's a psychiatrist, psychologist, social worker, licensed counselor, if you get that peer support, the outcomes in terms of rehospitalizations, interface with the criminal justice system, all kinds of things are much better with that peer support. I mean, peer support works. It's something, there's a lot of evidence behind it, and I think that that's something that I do think that payers are starting to recognize that and are covering it, and I think that's important. And I think that when it comes to provider shortages, as you mentioned, there are some ways that you can telepsychiatry and other forms of telemedicine are a great way. The psychiatric collaborative care model that you mentioned earlier, that's a way where you can get a more efficient and coordinated delivery of care and has much greater, has great efficacy and good return on investment. So I think there are lots of innovative ways to dealing with provider shortages, but also, when you do have provider shortages, you have to make sure that there's as much of incentive as possible for them to join a network.
Do you think there's policy levers there to perhaps require peers be added to a provider network, for example?
Yeah, I think the organization Mental Health America actually has model legislation written up that would do some of that. So I think that, so if you're looking for policy levers, that's an organization, Mental Health America, that I think does have some solutions when it comes to this.
Great. They're a good partner on the peer front with 2020 Mom as well, so thank you for that. Did you have something you wanted to add?
Yeah, I think it's important to look at the data for peer support. And it's been about 6 months, honestly, since I looked at it. But when I did, I found more in the space of oncology, for example, or other parts of medical care than I did for behavioral health. That said, we are moving at Cigna forward in looking at it for substance use treatment. We've been undertaking a major effort to combat the opiate epidemic. But I think particularly for our purposes here, as I've heard just about heart-wrenching cases of inadequate care, let's make sure that the peer support helps. And maybe it does, and I haven't seen the latest data, but that would be my one caveat for this group.
We have great research, and you'll hear about it tomorrow.
Okay, good.
Good.
Excellent.
One final question before we hear from each of you again and open it up to questions. There's this concept of insurance parity with behavioral health and medical contracts. So you all may know and have an insurance policy yourself. You're written, and we can pick on Cigna, I think, a bit here. Cigna Healthcare of California is my medical insurance policy. But my behavioral health insurance comes from Cigna Behavioral Health of California, a separate company. We know there's other mental health carve-outs, right, insurers. And this fragmentation, we heard the cardiology example earlier from you, Tim, which I think was a great one, but there isn't a Cigna Heart Health of California company. And so I'd like to just hear from folks on the panel briefly about what these are barriers, I think, that both providers, so hospital, for example, in Stephen's case, maybe there would be a hospital that would want to provide behavioral health treatment, but they only have a medical contract, so they're not providing behavioral health care, and they haven't thought about, well, I need to go to a separate company and serve this person to give them behavioral health care in a hospital setting, for example. and just patients being not well, right, and depressed or anxious, having one more phone number to call and system to navigate, or an OBGYN needing to call versus talking to the dermatologist down the hallway who's on the same panel. Those kinds of things seem to be difficult for patients and providers to navigate. Anyone have a response on that? And Tim and David, please share your thoughts.
Well, I do think it sends a terrible message when you turn over your insurance card and the mental health and substance use benefits are at a different number. It really reinforces that it's separate and probably unequal. And that's not a good message. And the Federal Parity Act doesn't make any distinction between whether it's one company or two companies that are managing the different benefits. And so we need to de-silo our healthcare system, and that includes our insurance system. And so hopefully more insurers will get rid of this bifurcation. And I really don't think we should accept it. I don't think there's evidence that it causes major problems, as you suggest, and we should look at ways of at least discouraging it, if not insisting that it's all housed together.
Great.
And let's not forget the fun experience of mental health carve-outs, where you have a thing on your card that says this is your insurance benefit, and then you go and call that person, and they're not in network, but it says you're in network, and what's going on? It's because it got carved out to some weird random company like Beacon or Magellan or something else, and you're like, wait, what's this about? Yeah. So that just complicates things, and it's not straightforward for the patient. So all under one roof model in an effective way is a good strategy.
Dr. Lustig, don't feel like you need to respond, but feel free to if you'd like to. Tim.
Yeah, I think that when you have those carve-outs, as David said, the law says it doesn't matter if you use a separate company, you have to follow the law still. And I think what I've found in working with regulators and working with the plans that do use those vendors, you have two separate companies. You got one company doing the behavioral health benefits, another company doing the medical benefits. If they're not coordinating very closely, the only way they're in compliance with the law is through blind luck. So I think that challenge, I've worked with insurers that have those behavioral health managed care organizations, and it's really hard to coordinate. So I think that when you have that bifurcation, you have those carve-outs, especially when they're separate companies owned by completely different entities, it makes it challenging to be in compliance with the law.
Go ahead.
Yeah, I have a comment about a related issue, as opposed to which company you're with. It's just the going to an in-network facility, to an in-network ER, and then finding yourself in an out-of-network, at their out-of-network inpatient unit for behavioral health, which there's which could be an issue for folks taking care of our patient population that we're talking about, because that happens probably more commonly than we would like. And how do we address that issue?
No, that's helpful, thank you. In the interest of time, I want to make sure we have time for questions. Is there anything burning, so we're not going to go down the line, but anything burning that you didn't get to address that you feel like you need to, panelists, before we open up for questions? Okay, Yasmin.
In regards to the insurance and people not accepting my insurance, I called Alexis's foundation, and I knew that I needed proper help, and that this was before we met. I got denied in that and got told an astronomical number that I would have to pay, and we're a one-income family. And also when you're dealing with any type of mental illness, but I obviously know more about maternal mental health, the last thing you want to be doing is calling multiple numbers and getting voicemails. I'm full, I'm sorry, I can't accept you. I can accept you, but it's going to be about $200 an hour. Or, why don't you just try in-network, keep, calling in-network, which I did. And it was extraordinarily frustrating to the point where I almost gave up, because you can only get no so often, and when you're not only dealing with postpartum depression, but then you're having to advocate for yourself, it's exhausting. It's exhausting. I've said to my husband, I don't even know how I'm still here, because I just was hit with so many blocks that I just kept fighting and fighting and fighting, and that's why I'm so passionate about this, because I don't believe any woman should have to go through this, and spouses should have to see their wives suffer. And my husband will attest, he doesn't know what to do. He doesn't know what, I mean, he hasn't dealt with having babies and growing babies. He's the biggest support, but it's just not right. So something needs to get done, because we can't keep losing women because of either lack of insurance or lack of education for medical providers. So that's my 2 cents.
Thank you. All right, it's your turn. We're collecting cards, and we also are reading from the app. Very good.
Hi. So one question or 2 questions from online. What are your suggestions for figuring out what network adequacy looks like for various insurance companies in different states? We tried calling companies a number of years ago and either received no callback or they were directed to the lawyers.
Well, I think just documenting, those types of, you can test, if you're an advocacy group, you can go through and test in-network, in-network directories to see, what they say is available versus who actually is available, and like whether they're actually still in network, whether they're accepting new patients, and bringing light to that type of thing can be very helpful in pushing regulators where there already are laws on the books. Regarding network adequacy and timely access, and in other states that may need stronger laws, pushing for those stronger laws. So I think that's critical, is testing of network directories to make sure that they're accurate and that they're also adequate.
Yeah, I would just add, from an insurer's perspective, there is a great deal of sophistication that goes into assessing our network, and this is true for all companies, I think. There are a number of metrics that we look at, ranging from how many providers per population in a specific area, how many providers within easy driving distance, or within time it takes to drive, or distance. So those are the kinds of things we look at to do our best to ensure network adequacy. And as you've said earlier, it is a huge challenge for mental health, but those are the kinds of things we look at.
I'll add to that point as well. Coming from a compliance department at an insurance company, California has some of the most progressive laws around network adequacy and provider directory accuracy in the nation. So a California model is something to look at from a policy perspective. Also, you have state regulators. We've heard alluded to the fact that there are regulators that oversee insurers, and that person who had trouble getting a response, you should be calling the state regulator to say, I need help with this assessment. I will tell you, there's a gap in California that for behavioral health requirements, insurers are not yet required to talk about subspecialty, so it's only licensure. So how many LCSWs, how many psychiatrists, how many such and such. It's not how many, not yet, right? Perinatal mental health providers, it's not how many child therapists that specialize in OCD, for example. That's a significant gap, and until that's measured, we're going to continue to have problems. More questions?
Yeah, I'm going to hand this to Wendy because she's right behind me with her card.
That's what you have to do to get the mic, is stand right here. Thank you so much. I just want to thank all of you. Your interest and your compassion is obvious and inspiring. I wanted to say that this is one of the reasons that there's so much we can't do in this room, in this world, but we can really create a bridge, a better bridge. So that's one of the reasons PSI has a national perinatal mental health provider directory. It's online. I did a quick search. Megan, there's 190 California perinatal mental health specialists on the online directory. So just go psidirectory.com and you'll find that. And that's why, because as you all said, nobody should work this hard, including insurance companies. Just a little, 75 of them provide online services and 25 of them are Cigna providers. The Maternal Mental Health Task Force also has an amazing provider directory. So you have to let the social support organizations help build that bridge, and we don't want anyone to have to search that hard.
Thank you, Wendy. And one thing we'll add, and this is another lever for all of us in other states, is we can take those directories, and we did this in California. We took the list of all trained providers, not just with the new certification, but any trained provider, and we gave it to the regulator. And they're interested in starting to look at how many of these providers are in each of our insurance networks in the state of California. So these are things that 2020 Mom can assist other states in doing as well. Great.
The insurance companies are also using psidirectory.com when they're looking for providers. So thank you.
Yep. Thank you, Wendy, and thank you to Maternal Mental Health Now as well for maintaining those lists. Hopefully someday we won't need them, right? Just like we don't have separate lists for cardiologists, but we need you desperately now. Thank you, Wendy.
Here's a question concerning the shortage of professionals entering the mental health field. My experience, not mine, but the person who wrote this, as a nonprofit training agency, is that insurance companies do not reimburse for licensed MFT interns who are certificate trained in postpartum depression. Why is this any different than seeing a medical intern or nurse practitioner?
So I'm not sure if I can speak exactly to how it works on the medical side of Cigna, but we do need a licensed clinician to bill under, so they may be working in tandem perhaps with someone who is licensed. That's not uncommon for psychologists at various stages of training. I'm not sure how it works for medical interns, but it's a good question.
Yeah, I don't know the specifics of that particular issue, but I will say that the pipeline of providers' current reimbursement rates affects that. Because you have people looking to go into the field and they can see the landscape and they can say, I'm not going to be able to make ends meet, I'm not going to be able to have, I'm going to go into some other specialty that's more remunerative. And so that's also critical for getting the pipeline going in, is getting current reimbursement rates higher.
Excellent. Well, we are out of time. Keep the questions coming in the app, though, and we can encourage our speakers, our panelists today to help us answer those in the app. I want to thank this esteemed panel. I think it was a groundbreaking discussion. This kind of discussion I don't think has happened much before, so we thank our experts and our mom and our patient and our mom and our provider. Thank you so much, and Dr. Lustig as well. Help me give them a round of applause.